Thank you all for attending our monthly seminar series. Today we are having this seminar online with our distinguished guest, Professor Salman Kirmani from Pakistan, Aga Khan University. We are here in Izmir, in Izmir Biomedicine and Genome Center. It's one of the largest biomedical research centers in Turkey, and through the European Union's supported RHA project, RareBoost, we have the capacity development for research and soft skill development task for the region and also the center. And Professor Kirmani is a distinguished medical geneticist and pediatric endocrinologist at Aga Khan University, and he has developed a pediatric genetics clinic, hereditary cancer clinic, adult neurogenetics clinic, and the perinatal clinic at the first in kind in Pakistan, and he has over 100 peer-reviewed publications and pioneer in Pakistan's first system also for the undiagnosed disease program, and he is also our partner in Undiagnosed Disease Network International, UDNI, working closely at the several committees. And through this, he's also appointed as a undiagnosed champions for our region. So we are very happy that Salman is here with us today, and he will share his experience on that wide field. Thank you, Salman, and good morning from Izmir. And please feel free as in your presentation. And if you have any questions, please write into the chat, and at the end of the session, we will have the questions.
Great. Thank you so much, Ugur and team from Izmir, and thank you for all the audience for giving me this opportunity to present our journey for delivering genomic services in low-resource settings. Obviously, I am going to specifically talk about my experience in Pakistan, but I think a lot of what I will say will apply to many other settings, in settings that you may be working on too. So again, very, very heartened about the opportunity. And with a number of Turkish colleagues, we have great collaboration. Ugur has always been very kind, and we're trying to work out a undiagnosed disease program with his team. And I see that Frida has joined, and the Intergen team in Ankara has also been a good partner for us for our clinical testing. So very heartened between the collaboration we have, not only with the UDNI and the rest of Europe, but particularly with Turkey as well. So I'll begin, and I have no financial disclosures, no conflicts of interest. I will be discussing names of some pharmaceutical companies and their products as it relates to the precision therapies for rare diseases. So, we work in challenging settings, and as you can see, Pakistan is right here and is classified as a lower middle income country. But then you can see that a lot of the disease burden that we see, especially the consanguineous unions and a lot of the other tropical diseases, infectious diseases, malnutrition, are also affecting this region. So this region is a hotbed for a lot of problems, and how do you prioritize rare diseases within this is a challenge. It's a huge volume of people, a huge burden of disease. As I mentioned, because of the high birth rate and consanguinity, we see more rare disease compared to other parts of the world. And I always keep arguing that in our part of the world, maybe we need to use a different term. Maybe rare disease does not really do justice to our patients. And also, now that therapies are available, the injustice is even more pronounced and even more visible, because now you cannot offer the therapies to those children and families where previously there was no therapy available. So Pakistan is uniquely situated, as you can see, and there are very strategically placed, but economically and politically we struggle. And even though our neighbor India has progressed very nicely economically, we have struggled because of political strife, and we have not been able to benefit from collaborations with India, unfortunately, because of political tensions. So privately, I've learned a lot from colleagues in India as well, and I'm thankful to them. But because of our location, we are unable to actually do meaningful collaborations with a number of countries that we would like to. There is inflation in our environment. Our currency keeps getting devalued over time. There is political instability that I mentioned. And on top of it, when there are challenges of terrorism and then now climate change, it is very, very challenging for health and health priorities to be set. These are some statistics about Pakistan. People are very surprised to see that we are the 5th largest country in the world according to population. There is illiteracy, very little spent on health expenditure, lots of poverty, but we are a very young nation. So I think there is a lot of potential in us. I just hope that we can realize that potential in the future. So I keep mentioning that, the population and the burden is so much that sometimes we cannot even begin to try to tackle a problem. So for example, if you were talking about having a newborn screening program in a very, very large country with so many people, how would you apply that universally? You can apply that in small settings, but to do it universally is a challenge. The other big challenge, as you can see, is the consanguineous marriages. And Pakistan officially is the most consanguineous country in the world. You can see that, even within the Muslim countries where consanguinity is culturally practiced and is more common, Pakistan actually tops the chart. And we all know that this increases the risk of birth defects and recessive disorders, and it's much, much more than in other settings. So within this, a rare disease, unfortunately, gets low priority. Because of all the other diseases that are there and prioritized by WHO and the local agencies, I really feel that there is an unrecognized neonatal and infant mortality due to genetic disorders that doesn't get documented, doesn't get counted, doesn't get diagnosed. So we actually don't know what we're missing. As I mentioned, extremely challenging to have any epidemiological data because we have no national newborn screening program. And even in the clinical setting, because people are paying out of pocket, and there is no real government insurance program to subsidize healthcare costs, genetic testing by clinicians is considered a luxury. And even though they are aware of it, they may not refer the patient to a genetics clinic because they feel it will not make a difference and it's very expensive to get testing. The public also, unfortunately, has some cultural taboos and some alternative explanations for genetic disorders. And so they may not themselves seek care that they need. And the healthcare force in general does not understand genetics very well. And so because of that, they may not even appreciate that a family or a patient may be suffering from a genetic disorder. So multiple problems. And because of that, our population is globally underrepresented. And all of you know the challenges of that now that we're doing next generation sequencing and we're getting data, we are not able to utilize that data into meaningful clinical information because we cannot classify variants, according to prevalence, etc. So we struggle. And this is a big problem. And that's why not only the clinical setting has to improve, but on the research setting, we have to do a lot of normative data. We have to do population studies on healthy subjects to really, really get a sense of what the genomic architecture of our population is. Because even within South Asians, there will be obviously differences between India, Bangladesh, Afghanistan, Nepal, Bhutan, etc. So we need to actually study the country, and within the country study the ethnicities, and then only we will be able to really sort this out. So as I mentioned, the healthcare workers, the doctors, the physicians, they don't understand genetics and don't appreciate it very much. Local testing is expensive and very, very patchy. And I'll talk to you a little bit about that, the cultural challenges, and then the affordability. So if I were to summarize, these are the 4 areas we really need to work on. And this is again, statistics compared to developed parts of the world that, so for example, US and Canada have one genetics provider per about 60,000 people. In Pakistan, we only have 2 trained clinical geneticists and 1 counselor. And now we just doubled it. Actually, we have 2 genetic counselors now. Just last month, our second genetic counselor graduated from our program. So really, really, really underserved, as you can see. And even from the international context compared to Europe and even lesser resourced countries, we are struggling with having people who actually understand clinical genetics and genetic counseling. And by the same token, the labs, the laboratory setup is not mature enough. The government sponsors and subsidizes labs that are built in agricultural settings, and they are disconnected from healthcare. So there are next generation sequencers that are doing work on sequencing fruits and vegetables and a lot of botanical substances, but not really patients and rare diseases. Microbial genomics has taken off after COVID, especially, and with typhoid and TB being big disorders, a lot of epidemiological surveillance is now dependent on NGS testing. But that's good news for rare disease, because I think we can use the same infrastructure then to build on that. I'll talk to you about how limited we are in our genetic testing, and so we have to outsource to labs in Europe and US. And Turkey, as I mentioned, has been a very, very amazing partner for us with regards to affordable testing for our patients. And because of this poor infrastructure, we actually don't have people who understand rare disease bioinformatics, rare disease interpretation of NGS data. They think that NGS is NGS, anyone can do it, but we get some very, very junk information from laboratories that are claiming that they have made a report, but it's really junk data, and a lot of bad clinical decisions can be made on it. So this is a tough time for us. If I were to give you an idea of historically how rare disorders research has evolved in Pakistan, there are 3 main models, and I'll introduce you to those 3 models over time. And they have all done their part. There are challenges with them, but we have to now move on and do something more sustainable for the future. So in the community research model, what typically happens is that there are inspired and well-qualified researchers within Pakistan who are collaborating with more mature institutions, either in Europe or the US, and teams are sent to the field for sampling, and just by word of mouth, people know that, oh, in that village, there is a lot of birth defects or childhood disability or a particular phenotype like microcephaly in this slide, for example. And so people will go, they will collect hundreds of samples, they will get pedigrees that you can see how complex the consanguinity is in these pedigrees, etc., and so forth. And then, traditionally, these samples have all been shipped abroad. And on the good part, the PhDs and the postdocs from the Pakistani institutions go abroad and get their training and do their projects, on those sample sets. And then now, slowly, some of those people have started coming back. But unfortunately, because of the economic and the political challenges, there is a clear brain drain of these brilliant scientists from Pakistan who end up living in Europe or the US and don't come back to Pakistan. And so that contribution back to society is not really happening as it should. But nevertheless, a number of very important programs have been initiated by these great Pakistani scientists. Some of you may know them and have read their papers, etc. And it's interesting how much the Pakistani community and patients have contributed to the understanding of rare diseases, in particular hearing loss, microcephaly, retinopathy, etc., and so forth. So lots of opportunities still. I believe this is still just the tip of the iceberg. In the clinical research model, it's slightly different from the first one, because here what has happened is that at a busy government hospital, again, an inspired clinician has made a collaboration with some diagnostic companies abroad who have some funding to do either free testing or very, very low cost testing. And people come and they collect samples, and then whole exome sequencing or whole genome sequencing is done. And this has led to some good research coming out of Pakistani patients. The good thing about this model is that, unlike the first one, all the patients and families get a clinical report. Rather than just they might in the research model, they might not even get a report. No one might even bother to go back to the villages to actually tell them what the gene was or what the mechanism was. So here, at least then, these families are taking these reports to the clinicians, excuse me, and the neurologists and the cardiologists and the endocrinologists are all looking at these reports, and because they're written for clinicians, they're a bit easy to understand, and when the diagnosis is made, they see the value of that, etc. What we've done is a bit different. So I'll introduce you to the institution that I work for. This is the Aga Khan University. It's a private university in Karachi. We are an internationally accredited hospital. We're a university hospital with a medical college and a nursing school and a graduate school with PhD programs, etc. We have basic science research labs. We have clinical labs, etc. But again, we are in one of the largest cities in the world, Karachi, which has a population of about 25 million. So the 600 beds obviously cannot serve the needs of not only our city, but because we are a referral center for the entire country and region, we actually struggle also, because again, this is private healthcare setup. People have to pay out of pocket. There's no government insurance. It is challenging. And so when they come with complex problems, they usually run out of money by the time genetic disorders are discussed and testing is discussed. We try to give some welfare support, and about 25% of patients get welfare, but it's usually not enough. And again, genetic testing, clinical testing at least, is so expensive that we are not able to provide full welfare for those patients. But in this model, at least we try to do what the developed part of the world does, is where there are clinicians dedicated to genetics. So there are clinical geneticists, and now we have 2 genetic counselors, as I mentioned. We have a diagnostic lab. The in-house lab does very limited testing. We outsource our testing, as I mentioned, to Turkey now. And then we get a genetic report, and we do genetic counseling and genetic clinical decision-making based on these reports. And this is just a spectrum of phenotypes that we have seen over the years. And obviously this keeps on changing, but you can see that, you would expect that the pediatric setup with neurological disorders, epilepsy, cardiomyopathy, etc., would be a big volume, but we have a very good appetite and good volume of hereditary cancers, because we are a big referral center for breast cancer. So we see a lot of testing being done, and the clinicians, the surgeons, and the oncologists are seeing good value in finding these families out with these rare hereditary cancer syndromes, and then managing them appropriately. So this has been our journey at AKU. Before 2008, there was really nothing, and it was pediatricians who had very, very good clinical skills, and they were recognizing syndromes, but they were not able to prove it and not able to do anything. So we sent one of our colleagues, Dr. Bushra Afroz, who's a biochemical geneticist, went to do training in Malaysia, Kuala Lumpur, and came back and established the clinic, and then started a metabolic service. And then I came back in 2014. And so, we kind of partnered together. So she handles the metabolic volume, and I do the rest, plus the adults. And then we trained our first genetic counselor, and then now our second And then we've actually also trained 2 nurses. So we have a perinatal genetics nurse and a metabolic nurse. So slowly that capacity is building in the clinical setup, and we need to do similar things on the research side. This is our local capacity so far. As you can see, the menu is extremely limited, and we still don't have clinical NGS testing for rare diseases. Even panel testing, unfortunately, is so expensive that it is cheaper for me as a clinician to outsource the testing. It's actually done for about half the cost if I outsource it compared to if I do it in-house on the NGS machine that they have now established, etc. So part of it, the fact that we are not doing NGS for rare diseases in-house is my fault, but I cannot charge the patient double when a similar test, if not better, because of the more mature clinical interpretation I'm getting from Turkey or other colleagues. So slowly we will build that, but we are on our way to do that. And we've published our experience and the spectrum of variants and mutations that we're seeing, and the cultural challenges, etc., and so forth. So I think we have now a critical mass that we have developed, and we hope that this encourages other young clinicians to do genetics training and enter the workforce, and to then be advocates for rare diseases. We've documented the cultural challenges that we have faced, and as I mentioned, in other settings you all may be facing the similar ones. There is a stigma around bad genes. Unfortunately, in our patriarchal society, the woman is always blamed because the baby was in the mother's womb, so they assume that, oh, it must be coming from the mother, it must be the mother's fault, and the man really does not take responsibility of that, which is really, really unfortunate. Also, we have a lot of clinicians and families coming to us. They understand that the first child may have had a genetic disorder, and they want treatment while they're pregnant for the second child so that they are not affected. And obviously, we counsel them about the 25% risk for recessive disorders. We tell them there is no treatment in utero or even before conception, and they are deeply disappointed. They think, how can it be? How can there be no treatment, etc., and so forth. So huge challenge. And for certain disorders where we talk about the possibility of donor sperm or egg, it is absolutely written off, saying this is un-Islamic, this is against our religion and culture, we cannot go down that road. And the woman suffers a lot in this joint family structure because there is a lack of autonomy, and they really cannot make their own decisions. Because of all these things, people tend to leave things to God, and they say that it's God's will, so if it's going to happen again, it's going to happen again. We do not want to have the responsibility of terminating a pregnancy on our hands. We'll just leave it up to God. So those are challenges. They also have this hope that, oh, the next child will be milder or may not be affected, and so they really don't have a good understanding of what they are signing up for. And especially for disorders that they have not seen. If we, like, for example, we try to counsel the young couples before marriage for thalassemia, if they have not seen thalassemia, if they're not aware of it, they'll have no clue what can happen and how challenging it is. So those are tough. The hereditary cancer syndromes come with their own challenges, etc., and so forth. And so, it's very challenging. When we talk about couple carrier screening or even, young person carrier screening prior to marriage or conception, there is this huge stigma in society about, oh, if the woman is found to be a carrier, then no one will want to marry her. And so this is a big problem. And there are some government programs that are enforcing thalassemia screening via hemoglobin electrophoresis for all young people before marriage. And the community is not interested in doing it because they don't want the woman to be labeled or the girl in their family to be labeled, because then no one will want to marry her. Genetic counseling is a huge challenge because we don't have certain words in our language, Urdu, for gene or chromosome, so we have to be creative and make up things. Very tough. So how will this change? How will we improve rare disease research and the clinical delivery service, etc.? We really don't have rare disease registries. People are working in isolation. Even our medical center is we try to connect with government setups, we try to connect with others, but as you know, collaboration requires a lot of communication, a lot of openness, and unfortunately, for various reasons, it really hasn't worked out, and there is no central body coordinating, facilitating, and encouraging it. So it can only happen if two individuals get together and then bring their teams together. So not as good as it should be. Because of that, obviously, if we do that, we will have better representation in global genomics databases. We don't today. I really feel that one of the missing pieces of data is quality of life measurement of patients with rare diseases in our country, and we don't have those studies. We have it for some other things, but not for rare diseases. And obviously, we have a desire to do translational research within our country so that the laboratory scientists and the industry, the biotech industry, develops locally so that we can develop our own low-cost solutions rather than hoping that big pharma will actually come and do it. People don't want to work in Pakistan. The international companies are not interested in bringing clinical trials, even though the burden of patients is there. They can recruit 20, 30, 50 patients with a rare disease within a month. There's something that in a European country will take them 2 years to recruit. But because, of various reasons that I mentioned, the clinical trials never get to our part of the world. We obviously need affordable genetic testing. As I mentioned, we're currently outsourcing. This is the $350 is now whole exome sequencing through one of our partners, Intergen, in Turkey. And whole genome sequencing is close to $1,000. So you can see if our population can still not afford it, it's still very, very challenging for most of our patients. We are unable, after diagnosis, to provide the simple things that other countries now can take for granted. So, for example, the special metabolic formulas, the food for medical purposes, it's not sustainable. People will struggle and get 1 can, 2 cans, 3 cans, and then once they realize this is for life or this is, through childhood, they stop. They cannot do it. It's expensive. There's no local manufacturing. These things are extremely expensive, and we have a lot of dropout from our metabolic program because of it. Cystic fibrosis we struggle with. We can make a diagnosis now, but we cannot get them the CFTR modulator drugs because they're unaffordable. Again, long chronic treatments. All of these things, I won't mention each one, but each one has its challenge, as you can see, and I'll use a couple of examples to show you. And this is the challenge for all of us, right? That these companies are pricing these drugs at such high rates that it just you cannot convince the government to adopt any single disease program because it will be so much. And so we struggle with these price tags and everything, and it's really unfortunate. Because of all this, the public then obviously will need to be educated. I think Ratna Puri from India has really shown me that if there's a good, strong patient advocacy group for a single disease or a group of rare diseases, they can leverage things that sometimes the medical community is unable to, and really move the government or move some private organizations to support things. And we are now working towards that because we feel because of the volume of patients and with some increased awareness, we will be able to do that. But again, I think some large scale public education will have to be done along this. So I will use an example of SMA, which all of you obviously know, and show you how there has been some good experience, but some bad experience too. So just for those people who may not know, SMA is an autosomal recessive disorder, rare in other parts of the world, unfortunately quite common in Pakistan. It's an irreversible loss of anterior horn cells in the neurons, so progressive muscle weakness, and in the severe form, type 1 SMA, early death, between 1 and 2 years of age, sometimes even less than that. This is what a typical child with SMA will look like. They will not be able to feed themselves. They will need respiratory support. They will unfortunately have a very, very tough and painful death. So the gene therapy, when it came, we signed up for the managed access program through Novartis. And within a year and a half, so this is data from 18 months, we had almost 50 patients who qualified, so 48 patients who qualified for the program. We counseled them, 3 were lost to follow-up, 6 were actually, the program closed down, and I'll show you how the program closed down, but we were able to process about almost 40 applications in the managed access program for this. We did AAV titers, and about 13% were disqualified because they were positive. 34 entered the so-called blinded allocation. All of you know this. This was essentially a lottery for life. But look at our success rate for blinded allocation. Out of 34, 9 actually qualified. 27% of those who entered actually qualified. I mean, that's actually better odds than any lottery, right? So again, the sheer volume of patients that we were entering every week or every other week allowed us to say, and we were really excited. But look at what happened, all right? Out of the 9 that actually qualified, 5 successfully got the drug, so total of 15%. This was very, very unfortunate. I had to make a phone call saying, hello, your child has just received the approval for the drug, we're ready. And they would tell me, she died last week. And so 3 such phone calls were made, and it's just, again, a horrible sight to see for patients to be so hopeful and then their child not actually being able to benefit. And one family lost their patients and started risdiplam because they couldn't wait for the allocation. But once they got the allocation, they were ineligible because, again, through a very unjust system, the managed access program through Novartis was saying that you can only get this drug through this program if you're not on any other drug. And so this patient didn't get it. But look at what happened to those who were waiting. Most of them died. Some of them passed the 2 years, they died later. And again, one of them started on risdiplam. So again, would you call this success? Oh, 15% got the drug, which was $2.1 million. They got it for free. Or do you call it an extreme failure where all of these people were just waiting and waiting and waiting? I had patients calling me saying, doctor, has my child won the lucky draw? I mean, can you imagine that a family is waiting for a lucky draw to decide whether that child will live or die? How unjust is that? And the justification was, now it's closed everywhere, and they just closed it in Pakistan about 2 years before they closed everywhere else, and they realized there was never going to be a market for it. The government was never going to pay for it, and even though they gave almost 300 free doses, I don't think it's enough. And so really, 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 really tough for us. And very interesting happened with the 6th patient. Only 6 patients in Pakistan have been treated so far. The father was quite savvy. He was a dentist, and he started a GoFundMe campaign. I'm sure in your countries, some parents have done this. In Pakistan, how much can you do to collect $2.1 million? It's never going to happen, right? There was a social media influencer, a local comedian, who picked this up, and he had just had a young baby himself, and I think he was emotional about it. He tagged a local politician who was very high up in the chain, and the elections were coming up, and he said, oh, this is your responsibility, you must do this. He got a phone call within 5 minutes from that politician secretary, and through public funding, again, this was taxpayer money that was used, the 6th dose was given, $1.7 million. It was slightly subsidized because the government was procuring it, but still obviously not enough. So interesting journey. On the other side, again, for this, for SMA, there was a very, very few patients who qualified for a compassionate use program. But then ultimately, we now have an active welfare program where there is a subsidy, but even with a subsidy of 66 to 80%, the family has a lot of responsibility on its own. And I'm getting patients who are dropping out of the risdiplam program because they can no longer even afford that 1 bottle that they have to pay for to get the 4 free bottles. Nevertheless, we have about 50 patients still enrolled, and there are about 500 in the waiting list. So you can see how tough it is when you begin a program like this for precision therapy, how much of a waiting list and line there is. So I give the example that, in a country like Pakistan, where we have one of the lowest per capita healthcare spending, if you can convince the world you are able to deliver the drugs for certain patients, not for everyone, but even if one benefits, I guess there may be a benefit. So I think, my message to the global genomics community and to Big Pharma is that you cannot have this payment model in our part of the world. You just cannot. It's wrong. And you will have to have some type of public health approach to this, like for HIV drugs and hepatitis C drugs, and subsidize them so that, we can do something. There should be differential pricing. There should be some outcome-based model, because no one can pay for this upfront. And ultimately, there has to be technology transfer, and local capacity has to be done. That's the only way. And I've heard some interesting things about Chinese products, where gene therapies manufactured in China are being offered for technology transfer in Malaysia and in Indonesia. And one scientist even contacted me in Pakistan to see if the pharmaceutical industry in Pakistan would be interested. So I think that could be something that could be done. But ultimately, at least for us, and I believe for a lot of all of you, we have to do prevention. The wave of these patients with recessive disorders is so much that unless we actually do the public awareness to stop the next wave, we will just have our hands, we will be fighting fires without actually having to do anything else. And that's what I feel that I'm doing almost on a daily basis. And the journey for rare diseases has to be, across the spectrum, from the clinical capacity to the research capacity and building the infrastructure. So I think, as I mentioned earlier in my talk, that I'm responsible for the outsourcing, and I don't feel too bad about it, because I'm giving the patients the best clinical product for the lowest cost. But ultimately, it will have to be in-house for long-term sustainability, and we're looking for colleagues to help support us in that. So the take-home message at the end of my talk is that in countries like Pakistan, we have a huge burden of disease with very few care providers. The families are crushed under the social stigma and the financial burden of caring for these individuals. And now that genetic testing is available, we must use it not only to diagnose the patients, but also to do the preventative carrier screening, etc., and counseling, so that the young generation does not practice the same level of consanguinity that their older generation did. Through research, we need to improve our representation in databases, so whoever is tested gets a better quality result. And you have to constantly be on your feet, have an innovative mindset, so you can actually, practice expensive genomic medicine, but do it at a cost-effective way in a limited resource setting. So with that, I would like to acknowledge, number one, our patients and families. The UDNI has been a fantastic and a very, very generous partner. I have met the nicest people in the world who will be willing to help at the drop of a hat, at when I write an email about a difficult patient situation or something else that I need, it's really been phenomenal. And with them, the Wilhelm Foundation, they have funded our genetic counseling training program. They have funded our travel to international meetings, so our genetic counselors and scientists and clinicians can be aware of what's going on in the clinical world, in undiagnosed and rare diseases, etc., and so forth. And obviously the global genomics community, who in general has been very, very helpful. So thank you very much for giving me this opportunity to present our journey in Pakistan. And I invite you wholeheartedly to come visit our country and visit our campus. And please collaborate with us if you have any ideas on your journey and how your journey has matured over the years. We want to learn from you and do it better in our part of the world. Thank you very much.